technique that they didn't really know about. And so they just kept going in, suction, 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 they pull it out, grab the tube, and they go in, and they're like, oh, we got suction again, suction, 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 suction. So they spent the last 2 minutes of their ride suctioning and bag, suctioning and bag, suctioning and bag. I think they finally dropped a king, which then eventually just gets pulled right out because there's so much blood in there, it's just gonna get pulled because they need the innovation thing. And so they spent the entire time trying to manage the airway. Did they have time to do any of that other stuff? Do they have time to trend their vitals? Do they have time to do any of that other stuff? No, right? And so in these significant head injury calls,
They get past A.
yeah, they didn't make it past their airway. They couldn't get the airway secured. And so this is where things just spiral on you. Like you want to do, like everything was going good, right? And as soon as you have one thing go bad, as in they couldn't get the airway, like nothing else went good. Like they just couldn't get it, and then next thing you know, like now things are, like they're going to move out, tubes are getting hung up on things, and now things are getting close to getting pulled out. And so when things don't go well, you tend to get excited and ramped up, and then you forget about, hey, let's just take a second, breath, okay? I told you guys about the whole thing about how I start whispering. It's like it just brings everybody back down, and that's what this probie needed. Is he needed somebody to bring him back down, because as soon as he was unsuccessful with the first two, he got wound right up, right? And then he's like, oh, we gotta do it, gotta. And so, break him. Yeah.
So not to like be afraid of trying to tube someone, but if we're talking about like a trauma,
No,
like a head
you're scared already just based on one question, Andrew. I can see already.
No way.
You and I aren't gonna get along.
Get along great.
I don't know.
Wouldn't it be better to just bag them instead of doing
If you
innovation
can,
attempts?
if you can, yeah, if you are able to manage with BLS, and the more I think about it, I don't know if they actually ended up dropping the king or not, because I think they were trying to intubate in the parking lot of the hospital on the 3rd attempt. Actually, I don't think they did drop the tube, now that I think about it.
Yeah,
I
what do
think
you
I
do?
just-
I know that once
You go in and let them do it?
He got two and everything, but then he
Yeah, no,
sat in ICU for, I showed up at 6:30 and that's about, he sat there till noon, and then he came up to the OR.
Are you sure this is the same person?
16-year-old, straight into a wall, car accident, massive, he went in for a craniotomy, was ours. I know the last name that they came up with.
I don't even know the last name.
But-
I mean, it was all over the thing. It's a little bit,
It was like, did they drop him off at Riverbend?
yeah.
Then yeah, it's the same.
Yeah. I'll talk to you at break, because I had different information about some other stuff related to it, but it doesn't matter.
I agree with your point on bagging, be it superior BLS skills, but he's filling up with blood. How much gas exchange are you gonna get when his lungs
Yeah.
are being
Was
filled
he
with blood?
filling up with blood from the
Gonna have to
esophagus or
make
the
attempts.
trachea?
What's the bleeding?
They don't know where the blood was coming from. I mean, it was enough that the blood was sloshing in the back of the ambulance when they go around the corner. Yeah, as soon as they, I got the phone call immediately after the call, be like, hey, this is what we had, this is what's going on. I'm like, oh, okay, because, so for starters, like, my people always call me on my cell, no matter what. They're always just like, hey, well, at night it's on vibrate, right? So luckily they're smart enough to call the station phone number. And I'm just like, and I'm super confused when I'm asleep and I try and answer the phone, right? They're like, hey, so we got this, and I'm just like, who is this? I'm like super confused, not even knowing what's going on. I'm like, and then I was like, hold on, let me stand up. So I stand up, gotta get my bearings. I was like, okay, start over, start over, because they were both wound up. Both members were wound up, and so they're like, yeah, we can't get the blood to stop dripping out the ambulance. We've had water flowing through it for an hour and a half now, and it is still flowing. It's like, okay, how are you guys doing? And they're like, well, I think you need to talk to so-and-so. I'm like, all right, let me talk to him real quick. You guys are out service, come on back. Long story short, they had to pull all of the striker self-loading stuff off, all the track and everything, remove all that, and hose and disinfect everything. It was bad enough that the kits that were on the floor ended up with blood inside the kits because of the amount of blood that was there. And so that is not your stress call, when it's your first big, crazy call.
Yeah.
You want those calls to go perfect, right? And so when they start to not go perfect, then it just becomes this big, hey, is it my fault? Is it my fault? Did I do something wrong? So you just gotta go back. And I asked them a couple times, they're like, hey, we did this and this. I was like, well, why'd you do that? They're like, because that's how we were trained. I was like, that's good. I was like, because that's the right decision to make in this situation. This is why we do what we do. This is why we train. This is why we practice in here. So that when you're in those stressful situations, you're always revert back to the training that you had. So that's why we put the pressure on you guys in here, so you guys will have that semi-stress situation. There's no way to prepare you guys for that sort of level of stress. I tried, but I don't get you. I would hope that I can't get you guys that stressed. So.
Yeah, so it was good that they didn't move past airway, because the airway wasn't managed, right?
Correct. You can't loop past. That's why. That's the idea. Is you
Yeah, it
don't
was
loop
like
past
stop
it.
and hold, basically.
Yeah.
I had a similar case of a girl that went into a rock wall on the way to Florence. She had four fractures. I mean, I had her on her side. She was filling with blood, and my whole way from halfway from Florence to Riverbend was keeping her airway clear. That's all it was. All I could do.
Section.
Yeah,
Well, vital
it's like,
signs, suctioning, and managing airway.
how do you not just like poop your pants immediately when you see like a fracture? Like, aren't you worried that you're gonna like sever their whole brain from everything? Those pictures were
But
terrifying.
didn't they already do
Just
that?
where the fractures are.
Yeah, just based on
The-
where they are.
So you're half the time you're not even gonna know that there's a LaForte fracture going on, right?
Unless
so-
you see their whole top.
Unless you see like the top,
independent.
unless they're doing one of these things with the top and bottom of their head. I mean, like you come up here and you're just like, oh hey, yep, we got paradoxical movement happening here, top and bottom.
I
We're gonna call that a LaForte.
Like 3
Um,
or 4, I don't know if it's.
But if you're doing a job
Retracting the floor.
Yeah, are you retracting your LaForte floor fracture?
My patient was conscious and learned.
How come nobody called him out on
I had her
that?
on her side,
Somebody did.
and she was grabbed, I gave her the suction thing, and she was able to.
Oh.
He was like a 3 or 4.
That was for you when they're awake.
Maybe for them.
Did the kid make it?
So we're just trying to figure out where this four fracture would be located.
Oh, yeah, sorry, 3. That was probably a 2. I think it was 2, before 2.
Okay.
Yeah, if you were to do a jaw thrust maneuver on that 3,
And the jaw
you
comes
are
off in your
so
hand.
hosed. Like,
No, because it'll stay totally intact with the back part back here. All that's gonna stay intact. Basically, it's your cranium portion that's gonna, like, as long as you're not trying to do one of these things, like, you might be okay, like, on a serious note, like, because look at where it's fractured. So it's fractured, like, basically through here, right?
But the
Back
back
down in that direction.
The
So all this
mandibles.
stuff is okay to move, right? So it's gonna move, probably pretty easy. And so you just got, basically, it's a disconnect between the top and bottom.
unless it's this
When it's,
and right where it's supposed to set up here, you
I think
grab
those
that
words.
and pull the front part.
Yeah, you're gonna, like I said, it's probably gonna move for you, probably pretty easy. Just
and when you have a back of the cranium fracture or open
Yeah. it-
part like
yeah.
that, do you still they backboarded them, like,
Mhm. So it's on the
Just-
side.
okay.
The
But if
kid
it was
on
in the
side.
back,
You just pad,
pat around.
put a nice big trauma dressing back there, which is gonna help with increase, with padding, but, yeah, you,
To not put pressure on.
yeah, you're gonna do what you can to.
Did the kid make it?
To be determined. I had heard no. I was notified by dispatch because they wanted me to notify the crew
Yeah.
that he did not make it, but that was before 9:30. And if Allie is saying he was in the OR at noon or
From-
something,
What I heard was he was kept in ICU as an organ donor.
oh, okay, so they
So
called,
he was
okay,
kept
they
stable.
had called 1249. Okay,
Uh-huh.
so they
Yeah,
pronounced
he
him
was
dead,
on an-
okay.
Okay.
Cause one of the anesthesiologists, when she looked at
Oh,
his
yeah.
chart,
Yeah.
said, it says organ harvest, I've never seen this on a patient
Okay,
chart,
so that would make sense then.
so.
Would you,
Yes, no, maybe.
after you are assigned, would you take like a CTOL route?
No.
And help innovation defense?
Andrew,
Andrew?
What
Don't-
was the question?
Okay, did you guys hear the question? So the question,
No.
question asked. Andrew. Question was asked if you would take the C collar off to help with intubation slash, or once they were intubated, would you take it off to help facilitate?
When they're under sedation, and someone could potentially help hold.
So I'm gonna say, Andrew, you are gonna be placed in judgment positions where you have life over limb and airway or no airway, and you will be put in the position of, is this C collar in my way, is it not in my way? And when it comes right down to it, it's gonna be a determination and a decision that you're gonna have to make of whether or not to take the C collar on or off. How's that for an answer? Boom! Politically correct, safe, all the way around.
Figure it out.
Don't take off.
Long story short, this person did not have a C collar on to start off with. Okay? Because of the airway management that was happening, their primary responsibility was is they were holding, and I guess it was a less than 5 minute kind of thing. They were getting all the other stuff happening. Their idea was hey, after we get this person intubated, let's get the C collar on, because they were holding C-spine and they were doing the life over limb approach with this kid. Did not have a C collar on, and they're like, well, okay, we want the C collar on before we roll in, right? Because we talked about this, you want them fully C-spined, you want them looking pretty when you roll through that door, right? Yeah, no, they never even made it that far. They made it to bagging is what they made it to, basically, on this one. So this is where you have all these great plans, everything wants to go smoothly. If it goes perfectly smoothly, they're rolling in with a intubated, totally secured, perfectly packaged, naked kid with a blanket over him, rolling in.
And knowing all injuries and.
Right. So what they rolled in with was a fully dressed, non-C-spine kid they were bagging with a BBM. That's what they were able to get across.
That was paralyzed.
What
That
did
was
I do?
probably paralyzed.
Was medically paralyzed.
Yeah, yes, sorry, yes, medically paralyzed, yeah.
Chemically restricted.
Does that, if you know you're not probably gonna be able to get the intubation done?
No. That is not the approach to ever take,
Goal is
Sarah.
to get the intubator.
Ever. You are the best paramedic in the world, and you will get the intubation every single time.
No, I don't mean that, I mean because of time. So,
Okay, that-
so your 5 minutes, it's the time thing, knowing
Then
how
you
much
need to
it's
be
gonna
faster at
take
your skill set.
to push your meds and for them to take effect, but you still just do it because you don't know what's gonna happen, right? But does that ever mean that you're rolling in and you haven't even tried an intubation attempt?
Nope, we stop in the parking lot there, like in the bay, and we do the tube right there. You can see the bay, the doors to the ER, and we've done tubes right there multiple times.
Okay,
Yeah,
Did you not push,
doctors hate it.
did you
Yeah, I
not
bet.
push meds on scene while they're in the car because the extrication time was slow? Or not, because it was fast? You guys not-
I mean, but
Yeah,
that
I would
doctors
say,
walk in and be like,
that would be my
okay, they're
guess,
medicated.
that the kid was
You
out
guys
fast
do
enough,
that.
because I would assume that they would have already given the lidocaine fed.
Yeah.
And basically, so as soon as the kid comes out, boom, the targeting sucks go in and you do it. And so, I think it sounded like they had the plan that it was gonna take a while, and then they came up with a secondary, hey, we can get him this direction quicker, and it saved a bunch of time, and they were able to get him out very fast, in relation to what they initially were anticipating. So, does that answer your question, Andrew?
Yes.
Okay. Let's see. Okay, bumping, yep, Okay, we talked about posturing
Are
stuff.
we gonna talk about amnesia? Like the retrograde versus retrograde?
So, like, what do you want to know about it? So,
Is there anything important other than the two?
no, just so there's no change in, medical condition related from one to the other, like one's not worse than the other. It's just a portion that there is some sort of, insult on the brain that has caused it, and being able to recognize, and so we give medications that cause some of this as well, right? Which medication is it? And so if we end up RSIing this person, more than likely they're gonna end up having some of this anyways, depending on the situation and the call. But as for the medical condition, one is not worse than the other, but any sort of amnesic effect secondary to a blunt force trauma to the head is something of concern. Because anything like that can lead to the edema, which can send you down the spiral of death. right? We'll just call that the spiral of death.
Dun, dun, dun.
Dun, 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 dun. All right, frontal lobe. Dude, so, you know how they do, lobotomies, right? Frontal lobotomies, change people's attitudes and stuff?
I'd rather have a bottle in front of me.
Right, the bottle in front of you would definitely be much better. So, funny thing with these is it's legit. We had a guy on the department that had a tumor in the front of his brain thing, size of like a golf ball. He was the angriest guy I've ever met. He was angry, like to the point where he was getting daily complaints. He went in and had that thing removed. This dude is like the nicest man I've ever met in my life now. And he's just like, he goes, I don't even know. He's like, I don't even recognize myself anymore. We're like, are you okay? He's like, I'm just happy all the time. I'm just like, oh, so this whole frontal lobotomy thing is like a legit, like,
That's what they did for women with opinions for many, many years.
with opinions?
Yeah, they did.
Okay.
Who wouldn't mind their husbands?
Wait, repeat that a little louder.
I'm kidding.
Are you sure that?
No, but they did. Treatment for hysteria.
All right, so repetitive questioning is one of the big things that you do want to look for. Somebody that's like, hey, what happened? Hey, what's going on? Hey, what happened? I think I ran that scenario with you guys.
Yes.
The cop.
But you had a smirk on your face the entire time.
It's impossible for me to stay straight faced, especially when I'm watching your guys' facial expressions, trying to figure out what I'm doing, and like when you guys start to think, everybody thinks differently, and everybody creates a different facial expression, and so it's really hard for me to stay in character half the time. And then, at the same time, I'm trying to figure out, am I going head injury or am I going obnoxious on this? It's all going to depend on how you come at me is how I'm coming at you. And some of you, I came back with, I'm like, oh, we're going to go this way? I can play obnoxious, James.
Yeah, you did. That's why you almost got ketamine.
Yeah.
Perseverating.
And so, as you see these repetitive questions, it'll be fun. It almost gets funny, like to the point where you can almost, after they've asked the same thing for the third time, you can almost kind of have a little fun with them, just to kind of test them a little bit, and you make something completely different up, and then see if they remember that's what happened. I had a kid on a skateboard get hit. He was like I don't know, he's probably maybe 13, 14, and he did get hit. He fell off at the skate park, hit his head, got his bell ring pretty good, just repetitive questioning the whole time. But of course, kids, with repetitive questioning is comical already, right? And so he's like, hey, what happened? I'm like, hey, man, you crashed on your skateboard, hit your head, da, da, da. 2 minutes later, hey, what happened? Hey, you crashed on your skateboard, da, da, da. And so on like the 4th or 5th time, I'm like, he's like, hey, what happened? I was like, dude, you will not believe what happened. I was like, so there you were, running across the street. There was a little baby down there. You ran over, you swooped up the baby, you saved the baby, you dove out, you sacrificed your body. He's like, no way. I'm like, yeah, man. I was like, it was amazing. I was like, they're gonna put a statue up for you, and he's just like, what happened? But it was funny, just the way he paused for a second, like get enough. He was tracking me enough, and he was like, no way. I was just like, yeah. So then I went back and I kept telling him, yeah, you fell off your skateboard, you hit your head, right? You don't want to mess with some people because they're like, you pick and choose when, just to test out some of your theories on stuff, okay? Let's see here. Brainstem compression, talk about Shane Stokes. Okay, there's some of our widening pulse pressure stuff that we're really probably not going to be able to see. Sluggish pupils, we've covered all that. Some low brainstem injury stuff. Got some hypotension response, ataxic. Everybody remember what ataxic is?
You need a taxi because you lost your balance.
Because Uber's gone, right? So ataxic is very erratic, has no sort of, so a lot of times with the Shane Stokes, you end up with a fast, slow, kind of a pattern to it. Ataxic is just very erratic, irregular, there's no pattern to it, there's no fast, there's no slow, it's just all over the place, lots of apnea portions of it, and it's just very, very irregular.
What was I thinking, ataxia?
Ataxic, not taxi, not taxi.
I was thinking ataxia. Is ataxia where you lost your balance? Never mind.
I don't think so.
Moving on. Okay, so we talked a little bit about the pediatric head trauma stuff with the bulging, slow progression with the ICP.
Yeah, exactly.
We all know how to C-spine
Taxi
kids,
has lost your
right?
balance.
The differences between C-spine in a kid and an adult.
Put it all under their shoulder.
Okay, so, yep, we don't wanna hyperextend their neck. Make sure you're ventilating appropriately. Oh, jeez, button pushing.
What was that, tongue push soft palate closed? Oh, I see.
Yeah, so basically it can,
Yeah,
it can occlude
got it.
everything, so. All right, neuro checks, right? So if you have somebody, repetitive kid, right? What neuro checks am I doing?
Pupils.
Pupils, LOC,
Pupils gonna be a slow or late reaction,
wait.
probably later. Oh, let's say slow or late. Thanks for really calling me out, I really appreciate you, I'm glad I was able to pick up on that, you guys completely glazed over right now.
Pretty much.
I thought it was like the 180 over 120.
Yeah, see, yeah, you're good, you guys are all tracking, yeah, okay. And so, we have pupils, what else are we checking? What do we check?
Orientation, music.
Okay, so this is that repetitive kid, hit their head. What kind of things are we gonna continue to check to monitor to see if they are bleeding or if this is a non-ICP?
Vitals, blood pressure, respirations, LOC,
Coordination.
So if I have
CMS.
increased swelling or anything on the right side of my head, right? I hit my head over here, boom. And let's say, for example, I end up with some sort of head bleed or ICP on this side. What would you expect to kind of see?
could we have left-sided weakness?
Yeah.
See, neurochecks are the same with
Okay.
stroke patients as they are with trauma patients, right? Grips, push, pull, movement, can you track, can you look at eye tracking? All, yep, and it's all ocular, it's not head, right? Because we got a C-spine going on, right? So it's all ocular movement, you're checking, can you do this, can you follow this, can you move these hands, can you do those kinds of tests? And you wanna do those early on, not in the person you're trying to manage your airway the whole time, right? But in the patient that is the repetitive questioning type of person, hey, do this, do that, take care of these neuro checks, and this is something you absolutely have to follow up on. You have to do a second assessment, roughly 5 to 7 minutes, depending on what your transport time is.
Do vitals, neuro check.
Yep, vitals, neuro check, as long as your patient isn't requiring a whole bunch of other management going on, right? And that's why if it is requiring a lot of other management, you have extra people, and if they're awake to be able to do some of these, then you would be having them do additional tests for you. Hey, do a quick neuro check, make sure you check grips and movements and stuff. All right, now I'm back doing this stuff, yeah.
Where did you see neurological deficiencies with the contra coup? I think that's the.
Coup contra coup?
Yeah.
It just depends on where the injury occurs in the brain. So most of the time, if you're gonna get with the right-sided injury, you're gonna get left-sided effectiveness.
Yeah.
If you have left-sided brain, then you're gonna get right-sided effectiveness.
Okay.
And so with coup contra coup, it depends. You can end up, if it's posterior, you could end up bilateral weakness. And so that's why it's very important to get full neurological effects right off the bat, neurological checks right off the bat, so that you can see if you end up with bilateral weakness now. Like, hey, before they were able to go heal the shin, but now this can't even, there's no movement here, can't make this work. It's like, oh, that's an absolute finding that you wanna document, notify the hospital that you're having changes in neurological checks.
It's almost like trending.
Absolutely, absolutely, yep. Trending just like you're doing your vital signs. So every time you do a vital signs in a stable patient, you're doing a neuro check as well.
Which means you don't have to do the same neuro checks.
Same neuro checks every time,
Over and over.
so that make sure that they can repeat the same ones. Same things, like you have them at your very first neuro check, have them remember something, right? Remember a question, remember color, remember something that's not special to them. It's like, hey, I want you to remember the color yellow. It's like, cool. You come back 5 minutes, hey, what color did I want you to remember?
Make sure you can remember it too.
That's why you always pick the best color, right? You always pick your favorite color, like your own color. So it's like, I know which color it is, right? Okay. So 20-year-old male in an MBA. This is how they scored their GCS, right? So they scored at 8. I don't know what the T stands for.
Tubed?
Wait, inhibited score 1.
There you go. So,
Throw that out there.
let's see, so that would be what, the it doesn't make any sense.
I guess what they're saying
Confused.
is.
Is there,
verbal
is that
was
your,
one.
your motor then?
It is localized, you got your now you got motor with localized.
I think the
You got
intubated
your
is
eyes
verbal.
opening, your verbal would be, yeah. So they intubated somebody that, so they did not paralyze this person, is what it looks like. They did not eliminate their entire paralysis, or their entire thing.
So then, how do they, oh man.
So let's just move on from that.
Okay.
Let's spend a lot of time, focusing on that. Okay, so pupil size, we've talked about that. Fixed and dilated, extremely hypoxic, also known as dead, right? A lot of the fixed and dilated, non-reactive. Drugs can affect it, right? Drugs can cause dilation, drugs can cause constriction.
Is it only fixed and dilated, or will it be fixed and constricted as well?
If they're dead,
Yeah.
if they're dead, most of the time they dilate out. And then they become non-reactive. So
Another
that's where-
patient came in dilated, and then after a while became constricted and fixed.
After they were deceased.
Well, he was brain dead. He hung himself, but they got the rhythm back.
So the person had circulation going then, when they constricted back there?
Yeah.
Yeah.
They improve
so-
circulation.
So you had improved circulation, so when you lose circulation and you can become hypoxic, hypoxia sets in, that's when you dilate out.
Okay.
Okay, we talked about bleeding of the face, right? Most of the time, it looks really bad, but they're probably not gonna die from it, right? Direct pressure is the way to fix it? Every time?
No.
No.
I was gonna say, unless it's on the skull.
Right? So let's talk MPA use on facial injuries. So I've watched, and I've heard a couple of you guys, like immediately on some of these traumas, immediately go and try and drop an OPA. So they don't accept the OPA, immediately go to an MPA. On an unconscious person. Related to a trauma.
So the MPA
What's
is
the
technically
trauma?
contraindicated with
Yeah. What's the trauma?
the facial fractures. But when we did our field guide for it, I read a study that said that that's not really an issue.
Right. You have like some very, very old CT scans and X-rays, like old, like the invention of X-rays, right? That show an MPA partially up into the sinus cavity and stuff, right? It's been a long time, it's very rare. Huh?
It's streamlining that oxygen.
Yeah, streamlining it straight to the brain. There's Cody. And there's Cody. I feel like if I had any energy to walk over there and write right now, you would be up there.
Why even?
So let's just talk about it. So it is a very, very hard thing. You have to have very specific fractures in very specific places. So anytime, a good practice to get it in is anytime you have any sort of facial fracture from here to here, attempt to avoid the NPA.
So that's gonna be an obvious facial fracture,
Obvious
'cause
facial fractures, yeah. So with that being said, think about it. If you have somebody that's unconscious, unresponsive, secondary to a traumatic event, if you're gonna RSI them, are you gonna go with head injury meds? Probably, right? So now you're thinking head injury related stuff, so now you start to think about, okay, there could be a head injury up here going on, I don't see it, could there be a fracture in here? So then you start second guessing, like, oh, should I put an NPA, should I not? So just think, the way I approach it, if there's trauma from here to here, like obvious facial trauma, that's when I lean towards not going with the NPA. You'll hear a lot of people that, oh, if they're unconscious in a trauma, you shouldn't do an NPA at all. I feel that that's not accurate, because you could have posterior ICP that's causing it, you could have stuff going on way back here, and you're not getting the oxygen in. So, before you drop an NPA, quickly assess, boom, push, 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 make sure everything's stable there. If everything's stable there and there's not blood coming from the nose, I would go ahead and drop your NPA. Anytime there's blood coming from the nose, I'm not gonna put an NPA in, because of the fact that there's so many different things that are back there, in relation to potential. Who knows where that blood's coming from? It could just be coming posterior pharynx area, but you just don't know. And that's some of the question with the rhythmics that I argue, and we're waiting for an answer on. So it'll be interesting to hear what Paulson says. So yeah. So clarified on the MPA, makes sense?
Yeah.
Use your brains, not their brains. Use your brains to figure this stuff out.
What do you think you want?
Like legitimately,
Let me just feel
you
that.
guys are gonna have to use your brains as paramedics, which is scary. Like you have to think a lot. Like
We're not nurses.
Right. Nurses, we don't have the doctor to ask, can we wipe the patient's butt or not? Right? What do? We grab the yellow blanket. We package them so that they can ask the doctor if they can wipe the patient's butt and clean it. Right? We just package delivery. I like wrapping packages. That's what I do at Christmas time. I'll be like, hey, I'll wrap all the packages. I'm good at that. I package people for people on a daily basis. Okay? Let's see. So checking the face for fractures. We kind of talked about that. Palpation, movement. There's nothing really. So if you have a fractured jaw, are you going to intubate this person?
Yeah.
Yeah, probably.
I mean, if they need to be intubated.
Okay, we're going to assume if I ask the question, are you going to intubate them? They need to be intubated.
Yeah.
We'll just say that.
Yeah.
They need airway management.
A wired jaw is.
If they have a fractured jaw, is bagging them going to be difficult?
Yes.
Yeah.
Why?
You
Seal.
can't fulcrum off.
Good seal.
Because the idea is with the jaw, you're pulling it to the mask, right? You're pulling the mask to the jaw, and you're basically pulling, and if you have a bunch of fracture, you're going to get instability, and you're going to get poor seal, yeah?
Yes.
So, intubating this person.
Hell yeah.
Easy?
No.
No.
Yes, the jaw's
Yes.
The jaw is super slack in there, right? You got no resistance. You're just like, it's like, oh, hey, let me move this part of the jaw out of the way. It's like, oh, like depending on how broken the jaw is, you can just be like, open it up like Predator style kind of thing. Just hey, we got it. We're good.
I really hope you make these comments when you're intubating.
Yeah, he does. It
because-
was
Oh, you
before I
don't-
got there.
Oh man, I am so excited for anyone that ever gets to run a call with me. That's in this class. Like it's a miracle watching like students that finally are like in the field that run calls with me and stuff. Like I have fun with them because I know that they're there, and so like I just do my normal thing. And most of the time I let them do stuff, but of course I've told you guys I'm always judging. Right? I'm always judging, so they'll do something. I'll be like, I mean, it was like a really good IV. I'm just like, so why'd you go with the 20? It's like, what's the point in a 20? I mean, anybody can get a 20. And it's like, you want me to get down there and do the 18 for you? I'm just constantly bantering.
Shit
students.
talking.
I mean, it's fun. Yeah, I mean, shit talking, really? I mean, that's really what I do. But it's fun. I mean, I love running calls with students. Last year, you guys know Kate Bishop?
Yeah.
So her first day internship at Eugene Springfield Fire, I just happened, because I don't work the ambulance a lot, I just happened to work in overtime. She didn't realize I was working overtime. So she shows up, and I think she almost like quit that day. Turned around and walked away. Like instantly, it was just like, like nerves, like, oh, it was horrific. I was like, hey, just so you know, it's a completely different atmosphere here versus at school. And she's like, oh, okay, awesome, yeah, good.
Because
So on the
they're
first call,
real
I was
people.
just like, so, what do you want to do? She's like, I'm just like, yeah, I'm just here to make sure you don't kill anybody. I'm like, you're the paramedic. I was like, starting off, not a very good one, but just let me know if you need to do something.
Right in front of the patient?
I don't say that. I do say it's their first day though. Even somebody that it's like they've been there for like 15, 20 years, they're getting ready to start an IV. I'm like, don't worry, ma'am, this is our best person. He's had lots of practice, but I'm pretty sure that you're his first human person. And they're like, what? I'm just like, yeah, it's his first day. And they're like, and then they instantly start panicking, and then we don't tell them the truth until afterwards. I'm like, I'm just kidding. He's been here for like 15 years, something like that. And they're like, oh, you really had me going, young man. I was like, oh, you call me a young man. That's the whole thing I was going for. It's like, yes, I'm not old after all. Because like, if you think about it, like, I say and I do a lot of stuff on calls,
You
but
want
it's,
to move vitals, you want to move heart rate, you want to like
yeah,
freak
like,
your patients out.
you're picking the time, like, because people, they're having their worst day, right? And if you can like bring them up and get them feeling a little better, we're not just there as medical providers, we're there as social workers, we're there as, hey, we're here to help you. And they're like, people will be like, oh, I'm so sorry for calling you. It's like,
that's all right, we're just sitting around the table at 3 o'clock in the morning playing pinochle, it's all good, we're good. And they're like, really? I'm like, no, we were actually asleep, but that's why we're here, that's why we're paid. And they're like, oh, that was actually kind of funny. I know, how's that busted hip doing? It still hurts a little bit. And I was like, well, how about we make you feel better? I was like, and they're like, that would be awesome. I was just like, okay, so a couple things. You like needles? No. I'm like, well, we got needles. And they're like, huh. I was like, could you do a needle for a short period of time? I was like, don't worry, I won't let him do it. I'll do it. It'll be really quick. If he did it, it'd probably take a while. And they're like, yeah, you can do it. I just do one of these. I just look over and I'm like, I got this. I go over and do my IV, do the thing. Like, hey, how would you like some happy juice? Right? Yeah, happy juice? A little bit or a lot? They're like, oh, I'll take a little. I'm like, a lot it is. And I'm like, and then I'm just like, so, is there anything else I can do for you? And she's like, by then they're just like, no, we're good, we're good. I'm just like, all right, you guys can go ahead and transport now. Have a good time. I'll go back to sleep. Right. So that's what we're there for. We're there, I mean, you pick the time and the place and the person. Like, there'll be times where I'll try pulling something off like that and it totally backfires. Right? And be like, oh, I'm gonna go sit in the rig. I need to put myself in timeout after that one. Shouldn't have said that. Picked the wrong place and the wrong time and the wrong person. Okay? It doesn't happen very often, but it does. Okay.
What's diplopia?
Huh?
What's diplopia?
Awesome.
Bottom.
Diplopia. What?
Eyeballs out.
The cup technique we talked about.
Cool.
Not the back in, but the throw the cup over the top of it. What about somebody that has their jaw wired shut?
Double
A
vision.
jaw wired shut. Do we intubate the jaw wired shut?
Yeah.
How?
You're saying you cut the wire?
Take our
Jaw wired shut.
Is that oral innovation?
Has anybody ever had their jaw wired shut? Why does somebody normally have their jaw wired shut?
Broken jaw.
Okay, so if you can manage this with a BLS airway, like bagging them, that would be the way to go. Because what they'll probably end up doing is they'll surgically go in there and slice everything open. If it's an emergency situation, you use your trauma shears, cut some of those wires, wire cutters, and just hopefully the person is paralyzed by then, right?
I was joking, so you can see the wires.
Some of them, yeah, depending on what mechanism they used to do it. And so a lot of times it's almost like braces, where they'll just put a couple of latches on the back there, in the very back, and pull it up.
And it's open the lips and lip.
Or you can come at them with like angle grinder, like while they're awake.
And then they open their mouth. And
They'll instantly open up. They'll break their jaw and avoid to an attempt to avoid.
Carry that on the ambulance?
No, we call it truck, which is what I carry, and so I get to show up, and then I get to make this scary. Fire up the torch. Here we go. We're gonna, right? Okay. All right. Anytime epistaxis, avoid nasal tracheal intubation. Did we practice some of the nasal stuff in the lab? Everybody get?
where we put it through the nose and then use our fingers to gingerly.
Yep. All right. Okay. Ears. We talked about blood fluid come from the ears. If it leaks, do our halo tests. Injury. Hey, looky here. It says occlusion of the retinal artery. An emergency. Talked about that.
What's the instant blindness?
Instant blindness. Yep. Covered all this.
That sounds fun.
See how much more we got. Okay, 4 slides. Let's see. Talked about hypoxia, hypovolemia, scalp avulsion. Derek talked about. Don't kink it.
Pina colada. What's a pina injury? Your ear.
Bone in your ear.
Cut it off. Put it as close as possible. I talked that. Remove, cover.
Soaking milk.
Indirect pressure. No, it does not say milk.
We don't soak it in milk anymore?
No. They actually, most of the time, they don't even keep the tooth. To finish it off real quick, had a kid knock his tooth out at camp. There was 300 kids in the swimming pool.
kid hits his tooth somewhere on the diving board or on the side, knocks his whole front tooth out, right? Snaps it right off. And he comes over and he looks and I was like, oh, that sucks. You're gonna look funny. And so like 20 minutes later, all of a sudden one of the lifeguards calls us on the radio and be like, hey, so we found the tooth at the bottom of the pool. I was just like, no way. Like, that's pretty impressive that out of the 300 people, they found a single tooth in the bottom of the swimming pool. And
Someone
so.
stepped on it. It's happened. I've
It
seen that
went
happen
into a
before.
foot.
So they called the dentist and stuff, and because it was fractured like mid-shaft, they're like, yeah, no, they're not gonna do anything for it, they're not gonna reconnect that portion of it, it's
I
non-nerve.
can make a necklace.
You can make a necklace.
Good.
So,
Always.
all right, you
There's
guys got
something
any
else.
questions?
Yes.
Yes.